This meeting is being recorded.
All right. Welcome, everyone. My name is Kyle Jackham. I am a licensed social worker and the program coordinator on the Crossroads for Hope team. I am joined by Francesca Mangano, our master's social work intern on the Crossroads for Hope team, who will be helping me behind the scenes. So any questions or comments that you have, drop them in the chat, and me and Francesca will kind of divide and conquer. And most importantly, our presenter today, Dr. James Salwitz, who is a medical oncologist at Astera Cancer Care. We're happy to welcome you to the first session of our medical marijuana education series. The first session is in partnership with Astera Cancer Care. To those of you who may not be familiar with Crossroads for Hope, we are an independent 501c3 nonprofit organization located in Bedminster, New Jersey. Our organization helps all those touched by cancer to move through a health crisis to become more active and empowered by taking control of their health and well-being. Our network of support embraces all people that are touched by cancer, the diagnosed, and their loved ones, providing access to resources and evidence-based programs of support, education, well-being, and hope, and also offered free of charge. We are committed to upholding the dignity of all people through respect for gender identification, sexual orientation, race, ethnicity, and income differences. Our vision is really to be a safe space to turn to first for restoring one's whole being and improve the life of people with cancer and their families beyond the diagnosis. During today's presentation, there will be a focus on defining medical marijuana, what it is not, and how medical marijuana can be beneficial to a person who may be going through cancer-related treatment. Feel free to drop any questions or comments that you may have in the Q&A box or the chat box, and we will try to get to everyone's question at the end of the presentation. There is a lot of people joining us today, so I apologize in advance if we are not able to get to every single question, but we're going to try our best. Thank you for joining us today. Dr. Salwitz, I will hand it off to you.
Thank you very much, Kyle, Francisco. I really appreciate the opportunity to talk to all of you today about actually one of my favorite topics, medical marijuana. So as Kyle mentioned, I'm a medical oncologist in practice with Astera Cancer Care. We're the state's large private practice, multi-site medical oncology and radiation therapy practice. We also have surgeons, et cetera. We treat thousands of cancer patients throughout the state on any single day. We were an early adopter of medical marijuana. It's been legal in the state for over 7 years, and we immediately became involved in dispensing it or prescribing it. It's been a really exciting journey for us. We have well over 1,000 patients that have become involved in the program. It's been a very successful part of our practice. It's something that we never thought would be as good as it was. We got involved in it kind of because marijuana sounded good for nausea and chemo, et cetera. And it turns out to be so much more than that, and so good for our practice in general that we're like thrilled. And any opportunity I have to speak about it, I'm happy to, because it's so interesting. So interesting from a medical standpoint, a personal standpoint, a cultural standpoint, a political standpoint. It's one of these things that you can be involved with deeply. We were involved in writing some of the regulations in the state. We've testified in Trenton on the expanded regulation and use of it, and we will continue to be strong supporters and providers of medical marijuana. So medical marijuana, or cannabis, as it's probably more properly, it should be more properly called, ain't new. This is actually one of the oldest therapies anywhere. So there is very solid evidence in showing that this was available in China as long as 10,000 years ago, and in India and in Egypt, the time of the pharaohs. It was used for a wide range of medical issues back then. It was available in several different forms. And we've actually found bricks of marijuana in digs in China and then in India. So this has been used for a long range for many practitioners for many years. It somehow was not, though, in Western medicine, if you will, until about the 1830s. And at that time, Dr. William Brooke O'Shaughnessy who was an Irish physician, decided to take a tour of India, and he ran into marijuana, which was cannabis, which was being used then extensively. And he spent some time there, and he learned about it, and he brought this back to England. And by the mid 1840s, pretty fast for that time, it was actually in the United States. And people adopted it very quickly. Of course, you didn't have to deal with the FDA, screening and all those challenges. But on the other hand, they did have to get across the ocean and start to grow it. So I'm always impressed how fast they were able to basically turn it, spread it around the world. It was actually in the first medical U.S. medical pharmacopoeia, which was published in 1850, and there was just history nuts. That actually was published by the New Jersey Medical Society. And then by 1860s, 70s, it was used by most physicians in this country for a wide range of conditions. Those conditions included tetanus, snake bite, tuberculosis, wasting syndromes, headaches. It basically included just about anything one could think of at that time. And by the 1870s, 80s, 90s, was being produced by a number of pharmaceutical companies. The main form it was in back then was a tincture. So it's basically an extracted liquid. There were some tablets available, but they were not very effective. But there were surveys, by the early 20th century among physicians that this was an important part of their armamentarium, and they were using it constantly. And was very popular. Several things started to happen to start to see a drop in it. And first of all, you started to get some other medications, particularly narcotics became available, and other sorts of pain medications. Secondly, the invention of the hypodermic needle, which wouldn't seem to stop you from smoking marijuana, except that people weren't smoking it. It was mainly edibles, at that point, tinctures. And you can't inject marijuana. So marijuana is not soluble, will not dissolve in water, and therefore cannot be made into an injection. And so as the pharmaceutical companies started to find things that could be injected and use the needles and stuff, it fell in some popularity. But this was still being heavily used in this country, in the post First World War, into the Roaring '20s, and even into the 1930s. And then what started to happen was a lot of bad publicity, and we talk now about how the internet spreads things that aren't necessarily true. The internet didn't invent that. And there are a lot of really negative, bad stories came about that didn't have any validity, about it causing insanity and about it being highly addictive and all sorts of bizarre things that weren't true. And so you had that kind of environment that started to threaten it a little bit. And then, a man came along, a man called Harry Anslinger. And for those of you that don't think one person can change the world, Harry Anslinger changed the world, at least in this area and in related worlds. So Harry Anslinger is an awful man, and was an awful man. So he was first involved in prohibition and was a leader in prohibition, which then failed. And so that fell apart, he was made the first director of the Federal Department of Narcotics in about 1931. And he decided that marijuana was the thing he was going to go after. And the reason Harry probably went after this is that he was he was a bigot, and he realized that cannabis was changing in our country. And what it was changing is that African Americans and Hispanics that were moving up from the Caribbean and moving to the South, moving up north, they didn't use tinctures, they didn't use edibles, they smoked it. And he decided to use this to some great extent to go after them. So when you hear about the movie Reefer Madness, he was one of the ones that publicized it, and he started to push out this wide range of negative publicity about how dangerous and horrible and addictive this was. He actually went after all jazz musicians. It really was a target of his, jazz musicians, because there was a significant marijuana culture around that, particularly Billie Holiday. He went after particularly. And he really pushed how negative this was, and people listened. So you started to see scattered laws around the United States restricting its use and availability. And then you have the 1937 Marijuana Tax Act, which was a restrictive tax act. And then by its surface, it just taxed this heavily. But it made it really impossible for this to be available widely. For your information, the AMA has gotten a number of things wrong over the years, but the AMA at this point came out very strongly saying restricting the use of cannabis marijuana was a really bad idea. But nobody listened. And basically by 1941, there were strong laws across the United States restricting this and starting the drop in the use of it, which essentially vanished. I mentioned, Harry didn't stop making damage by then. He was actually the director of the Federal Department of Narcotics through five presidents, all the way up to Kennedy. He's probably responsible for a lot of our restrictive laws, imprisonment, because he wanted all these people put in jail for marijuana, et cetera. He's had a major cultural effect on our country in pushing in this negativity towards marijuana and then other drugs around it. But particularly, he just really hated marijuana. So marijuana kind of dropped in use and then started to take off again in the 1960s. And in the 1960s, it was recreational. But as recreational marijuana kind of sped up, people started to notice that this was pretty good for symptoms around a lot of other medical conditions. Well, I don't think snakebite was among them. It did help a lot of other things. So people started to use this, and they started to see building some momentum that maybe this would become some medical available. The AMA, the Journal of American Medical Association, the New England Journal of Medicine, a lot of journals really said this is something we should be doing more. But unfortunately, 1970 came, and the Federal Drug Act came in, and the Federal Drug Act unfortunately had a section in it that it classified compounds. That's when we first did this in 1970. It classified things as there being schedules, and a Schedule 5 being something that's basically over the counter. You can take whenever you want. Has no restrictions at all. Something like like Tylenol. Up to Schedule 1, which is something which has no known medical benefit, is probably dangerous, addictive, et cetera. So that's crack cocaine. And unfortunately, marijuana got labeled Schedule 1. Now, there's an asterisk within that, which was actually put in by at that time, who eventually the gentleman became the governor of Pennsylvania. There's an asterisk that says they were supposed to revisit this in just a couple of years, and it was just basically put in there as a Schedule 1 to comment on that. This is now 50 years later, and we're still commenting on it. It is still labeled as a Schedule 1, as supposedly as dangerous as heroin and all these other horrendous, dangerous drugs, addictive drugs. And this has been despite multiple attempts by a wide range of organizations to change this from a Schedule 1 even to a Schedule 2. Schedule 2 is a painkiller, like oxycodone or morphine is a Schedule 2, which are legal, but Schedule 1s have allowed known medical benefit and are dangerous and therefore illegal to possess, use, and certainly prescribe. And importantly, if you can't get the drug, you can't do research on the drug. And so it's greatly restricted research, on this, since that time. And it's how it remains today. The tragedy to this is that there are a number of different organizations, like the FDA, that could actually change this with a stroke of a pen. It doesn't require an act of Congress. An act of Congress could do it, but it doesn't require an act of Congress to change it from a Schedule 1. But it is still labeled that way, and it's been pushed back a series of presidents and a series of FDA commissioners, et cetera, and is not, there's no obvious path that this would change, in the near future. Socially, however, 70s, 80s, 90s, people started using more and more marijuana for the medical use. That gradually resulted in a groundswell. Physicians can't take credit, and actually the medical profession, for a lot of things that have changed over time. And this is one of the things we certainly can't take credit for. Despite the AMA being pushing for it, it was the groundswell of people out there using it, saying this really helps my mother, this helps me, et cetera. There are a lot of good things. So states started to look at prescribing this to legalize this individually. And the first state was California, and passed Proposition 215 in 1996. And this was passed by the people, and this legalized medical marijuana in the state of California, and it was the first state to do so. Most states, including New Jersey, that have since legalized medical marijuana have done it by that mechanism. It's basically been by a vote. One of the problems is getting a politician to say, I want to be the marijuana politician. So a lot of states that's had to go. Now, other states, Hawaii legalized it by an act of its Senate. It can be done by that, but a lot of states have legalized that way. We now have 37 states in which medical marijuana, is legal. And we also have a number, as you know, that are recreational marijuana, including in theory in New Jersey. But medical marijuana is now legal in 37. It's labeled in 4 of our 5 territories, and there are also some modifications in other states that led it's decriminalized, which means it's not legal, but you can't go to you can't be it's not a felony for its possession in there. So these states have all built their own internal laws. Now, this doesn't change the fact that this is illegal federally, which has had some fascinating ramifications, again, if you like politics and, and history. And that is, so in theory, the federal government can go after physicians. It can go after dispensaries. You can go after grow houses. You can go after anybody that does this. And unfortunately, since '96, a series of FDA commissioners, FBI, federal narcotics, and presidents, sad to say, have taken kind of a hard line on this, and they have actually allowed federal government to go in and start, and enforce this. This resulted in some pretty bad outcomes until about 2016. In 2016, the House did something really clever, and that's the Rohrabacher-Farr Act. And the Rohrabacher-Farr Act, which is really clever and is law to this day. It has to be renewed regularly, and it's good until the end of this year, and will probably be renewed again. They keep rolling it over. Rohrabacher-Farr Act was really clever. They couldn't legalize it. So what it did instead is it said it made it illegal for any federal agency to use federal monies, tax dollars, to enforce marijuana laws. So the FBI can know it's in the Federal Bureau of Narcotics, and anybody else can know this is completely legal. They can't pick up the phone call to do anything about it because that spends federal money and dollars. And this is why the federal government, has not gone after it, because even though it's federally illegal, they can't do any enforcement of that law. So that's one reason that so that gives a tremendous amount of protection. That's one protection. Another protection is a very clever structure that a lot of states have taken, including New Jersey, which legalized this 7 years ago. And what they did is they said, listen, Dr. Salwitz has I have a federal DEA number, a number, so I can write narcotic prescriptions. So they could, in theory, they could pull my number, et cetera, and say, or they could do something else. Now you have to see if it doesn't interfere with the other act, but in theory, I'm vulnerable, or in theory, I'm vulnerable. They can kick in my door, go through our records, see all the patients that I've written for this for, and they could penalize me, or they could go after a grow house, or they could go after anybody involved in this whole thing. So what they did is they broke this, they separated it into its component parts. So in New Jersey, in order to, which we'll go through a little more detail, but in order to get a card to get medical marijuana, you have to go to a physician. And the physician has to certify that you have a diagnosis that qualifies in the program. But the doctor is not actually writing for the marijuana. They're certifying the presence of a diagnosis, which of course is what we do for a living, in any case. So that means that I'm not saying, here's a prescription for, for an ounce, et cetera. I'm saying, yeah, you have this. You have this condition. You then go to this. You then go to the state, because then the patient registers. Who then they're the one that says that is then writing the prescription, and then you go to to a dispensary. So the dispensary is not writing the prescription. The doctor's writing the prescription. The state of New Jersey is writing the prescription. And as much as the federal government might want to, it's pretty hard to arrest the state of New Jersey. And so, but they insulated and broke into pieces. And this has been a common model used around the country to basically break this in pieces. Now, you still have some restrictions because of that. Basically, you can't use, or I would suggest not possess, medical marijuana in a federal institution, which is why, unfortunately, you can't use it in most hospitals because they get Medicare and Medicaid funding. You can't use it in most nursing homes for the same, for the same reason. You have to be careful, in traveling with it, between state lines. Now, I've never heard of a problem. A lot of our patients have done so, but it's just, it's something to think of. In theory, something could happen if you were traveling an airplane and they opened up your bag and saw it. Never heard of a problem. We've had lots of patients being involved in this. They go back and forth to Florida during the winter, et cetera. We've never had a problem there, but in theory, it could happen. Now, again, the issue with that may be that it might require the federal government to spend dollars to enforce it, and that's probably the reason that people are safe. But you had to create this kind of very interesting structure, around it. And the final piece to that, of course, is that if you're taking in dollars, then they have to go to banks, and banks are FDIC insured. So so this is how they got Capone and other people, laundering money from illegal acts that was going to the bank. So banks have a problem, and you have a problem with cash in this business because then you can't use credit cards because same thing. So each state has had to set up exceptions for banking regulations within the state in order to make this possible. And this is also, unfortunately, the reason that insurance companies can't cover it, because they also have federal licenses, et cetera. This is why this is a cash business, at this point. So there is no insurance coverage anywhere for this. You can pay. So if the physician that writes for the narcotic dispensing, et cetera, certifies the presence of the diagnosis, that office visit can be paid, but the marijuana itself, cannot be, paid for. So that brings us to what we have today, and which is medical marijuana available in a wide range of states. So what are we talking about? So first of all, the difference between recreational marijuana and medical marijuana is that one is supposed to get you high, recreational marijuana, and one is supposed to help medically benefit. And the way you do that is by decreasing or regulating the amount of THC. There are the two main cannabinoids, chemicals in marijuana that give benefit. Are THC, which we're all familiar with, et cetera. That's what gets you, high from marijuana, et cetera. It's kind of it's a stimulant, and CBD, which is basically, balances that and calms you, et cetera. It's medical equivalent, of medicines we're familiar with as Xanax or Valium, but although it's not the same, it does not work in the same pathway at all. There are actually, however, 113 different cannabinoids. And many of them are active in other ways. And one of the challenges is because of the limited research we have still in the United States and even at the worldwide level on this, the use of the other cannabinoids and their benefit is not well understood. There's a tremendous desire, and in some countries, Israel, Australia, are trying to break down marijuana into its component chemicals and then work with the different cannabinoids to see how they work, because it's that subtle interaction, that gives benefit. Plus, it's also certain ones that are more beneficial. But the thing we mainly think about is that it's THC and the CBD. And the way you go from recreational to medical is you drop the THC level down. To some amount. So why recreational may have 15% THC, and some medical can approach that level too. Most medical has significantly less, even down to 0.5%, and that's how you can use it and not get stoned, and be able to function. For clarity, I have patients that use medical marijuana for various issues, particularly neuropathy, that use it in the morning so they can go to work. It becomes part of their daily life. THC and CBD have their cannabinoid receptors in the brain, actually throughout the body. They're actually mixed types of cannabinoid receptors. Some work on the brain as stimulating or calming. Some appear to have some anti-inflammatory effect, which gets people excited about the use of rheumatological disease. Again, data incredibly limited. But people excited, et cetera. And of course, there is the question of whether marijuana in certain situations may have anti-cancer effects or may affect other diseases. Again, with a lack of really solid research, either at the bench level or in the clinic, et cetera, limits our understanding of this, and when they may or may not help. how to use it, et cetera. So the moment we're stuck with the observations, that that really helps a lot of patients, et cetera, deal with illnesses, particularly, of course, as oncologists, particularly cancer, but many other illnesses. And hope as time goes on, we gain more research, more specifically, how to use this. Marijuana is available, in multiple different forms. Now New Jersey has been slow to do anything but available, for bud, the actual plant itself. The original law was pretty restricted to that. The original law was written because it can only be grown on site at the different places, and basically all you could get was bud. So people had to make their own tinctures or oils, etc. The new law has allowed us to expand it. There are now 23 sites in New Jersey, many of which are secondary sites for the original sites, and they can start to now share product across the sites, which was not a part of the original law. So people now, could share products. So, so while bud is still very commonly available in New Jersey, we're also, starting to see, more edibles. We haven't seen as much as other states. We don't have like an advanced gummy culture yet, or a product available in New Jersey, but we are seeing a lot of tinctures, et cetera, that are available in the state, which starts to give people, multiple different ways of using marijuana. And people can kind of choose, and adjust, from that. There are some 70 strains of medical marijuana that are licensed in New Jersey, which sometimes gets to people in the confusion because, this is a plant people are growing. So you go to one center, may have this available, and then they run out. Another center has this availability, and the program is expanded so much. You have well over some 120, 130,000 people in the program, that it has been somewhat challenging for some centers to keep up, et cetera. We have some hope that with the legalization of recreational, that'll put more money into this and help centers, expand, and make this, more available going forward. But, we'll see that, as they grow, plus, more products, available, for people. The thing about this, is the program, which is so interesting, is that structure that I talked about, how, and that is you're going first to, in New Jersey, you go first to a physician, and it has to be a physician that's certified in the program. Now, there are a lot of physicians certified in the program, and if you go on the state website, and NJMPMP website, it has a list of physicians who are certified. A physician who's certified in the program doesn't have to be listed there, because a lot of people just are restricting it to their own practices. But there are lists there of physicians that are available, that are seeing physicians, and you can pick and you go there. You have to, in New Jersey, first go to the physician. They have to have an understanding of your medical care and of your medical record, or already have a relationship with you. They have to have some sort of ongoing relationship with you going forward, at least on a yearly basis. They have to follow up, see what's going on, with your care. But you can be seeing someone for the medical condition, that the symptom, that is part of the medical condition. So you first have to go to a physician. By the way, this gives you different states, different things. In Florida, you go to your regular physician and he writes prescription, and you go to the dispensary, and then their physician then is the one that handles internally. New Jersey has a little bit different sort of structure, but you have to go to the clinician. You have to sit down. You have to review, their medical, their medical records. Just as you might want to own hang up, there have been some individuals in New Jersey have taken advantage of this, and you can see some real exorbitant prices charged for that first visit. I would advise shop around if that's what you're running into. This is a really simple thing to prescribe. It's a few clicks on a computer. So it shouldn't be, cost you, a lot of money. It doesn't take a lot of time. In New Jersey, by the way, it's still legal to do it by telemedicine. The governor was very clear on that. You can still, register medical marijuana telemedicine. So you sit with the clinician, and the clinician reviews whether or not you have one of the indications in New Jersey. There's what I keep having to check it because he's growing. There are now 18 indications in New Jersey for medical marijuana. And they include, of course, cancer, and they include HIV or AIDS. They include chronic pain of several different types. They include migraine headaches, Tourette syndrome, seizure disorders, intractable skeletal muscular spasticity, glaucoma. I can never figure out the glaucoma one. I still haven't figured out, because marijuana does decrease the pressure in your eye of glaucoma, but I don't know how you know that when you're using the marijuana. I still have not figured that one out, if the pressure going down. ALS, multiple sclerosis, muscular dystrophy, just terminal illness of any type, PTSD, which is some really interesting literature about that. Particularly, we think of PTSD as a war phenomenon, which obviously it is. Speaking in the medical profession, coming out of COVID, we're seeing PTSD in medical care, in healthcare providers. Like I was just talking to a young emergency room physician this morning about this, what happened to him. So having that available, opioid use disorders, as long as it's part of a program, et cetera, and dysmenorrhea. But if you don't qualify for any of those, the number one, you look at the list, I'm not sure you can see this, but the number one indication on the list is anxiety. Now, if you live in New Jersey and you don't qualify for that, then you're probably just not awake. So in New Jersey, that is by itself a pure indication for medical marijuana is anxiety. That kind of opens the door, for everything. So, you sit down with a clinician, they review your medical condition, and then assuming that, you qualify, which is hard not to, then what they do is they register you online. This is purely electronic. There is a form you print out. This is the form. It has no benefit at all except to give you some registration numbers. There's a place for the doctor to sign it. They don't have to because no one ever looks at this piece of paper except you. And if it's doing electronically, and they say electronically by email, they're obviously not signing it. Then what you do is, so what the clinician has done is certify that you have a diagnosis that is covered in this program. Then you have to register, which you do online, which all that is proving is that you live in New Jersey, because it's a state program only. Unfortunately, we've had, in the oncology world, we've had patients come in from other states to care for us, and they really wanted this. Not long ago, I had a 18, 19-year-old kid from Israel that came to us for therapy, and I couldn't prescribe it to him because he didn't have a permanent address in New Jersey, which he was getting in Israel. I couldn't give in the United States, so has its limits. But you have to register. That shows that you live in New Jersey. Now, what you do online, and it's a little bit annoying because they want a picture, a couple of things, but it's not rocket science. It's just a couple of clicks, et cetera, to get this done. Once you've done that, now there is a charge. Governor Murphy has really been able to reduce this charge. The original charge is $200 for everyone. Pretty much the charge has dropped down to $20 or less, and there are a lot of exceptions for the charge. Now, a lot of people that are already under medical care have an exception and just goes to zero for the registration. It's only a one-time thing. And then they mail you a card in the mail. It kind of looks like a driver's license card. And it's strongly recommended that once you're in this program and using the marijuana, carry that card everywhere. What's the card for? Frankly, the card is when New Jersey's finest pulls you over on the turnpike, you can explain why you have marijuana on the card, in the car. That's what it's mainly thing for. Once you have that registered, you can go to any of the dispensaries in the state. Now, when you're on the website, which is a good website, then you'll see, all these different dispensaries. But you have to click what you're going to, but you can change. Because they one will have something available, another isn't available, or an appointment instead available, or et cetera. They have sales. The greatest sale I ever saw in this area was a couple years ago, because I'm from the Vietnam era. They had a sale on July 4th for marijuana for veterans. So I just kind of stared at that. That was, I'm from the era when we were not talking to veterans because they were smoking marijuana. And now we're giving them sales on July 4th. So you can change between them. Sometimes you'll have a product not available, a product. And they make an appointment. The first time they make an appointment and you go there and you sit down with a marijuana counselor about this. Now, if you or your loved one or your friend is not capable of physically going, you can register as a caregiver and you can go. I think it's a good idea if the first time if the patient can go, but if not, but at least the first time, because at least they can talk to the counselor about it, and then they can pick which product better. So, like I said, there's some 70 strains, different things are growing at different times. They have different products available they're making from that. And they know best which product is available based on the symptom complex that you're having. There was a while, for the first couple of years, I tried to keep up all the different products that's out, and I kept telling people things, and I was getting called back, but they don't have this product anymore. They don't have this anymore. So I've pretty much given up on that. They know a lot more about their product, about the chemical, composition, how much CBD, how much THC, how much other cannabinoids, and the effects they're seeing in their patients, et cetera. And you sit down and you talk to them, and you figure out which strain or strains of marijuana, and how you want to do it. So again, you can take, you cannot do. Or now is like a parfait, you can do that, is that it works very fast. It works in 4 or 5 minutes. So it's very easy to decide, have I taken enough? Have I taken too little? I want to have lunch now. It helps my appetite now. So let me do that now. It's very easy to adjust that amount. So that's been very successful for a lot of our patients. And we are seeing more and more products available that make that very easy. Edibles are still, of course, very popular. The challenge, and that's great, and that works very well. Edibles are a little more challenging to use because marijuana, as I said earlier, is not soluble in water, which means it's poorly absorbed when you swallow it, which means it takes 1 hour to 2 hours to take effect. In addition to which, and this is a medically true statement, we know the pharmacology, edible marijuana swallowed it's more likely to get you high than inhaled. It has to change in the chemical in the liver that the change was what caused that. So what we've had happen, and again, it's just a matter of figuring this out. If that's worked for you, I've had hundreds of patients use edibles, but I've had people say, they make a brownie, they have 1 brownie, now they have 2 brownie, and I have 3 brownie, and then they sleep for 24 hours. So you have to be more patient. You have to learn to adjust, but people do. We people that vape during the daytime, and we people take an edible at night, and you have to, working the combination out. This is not like Percocet, any other medicine. You want to take 1 tablet every 4 hours is the dose. It's very individual. We're using a live product, a plant. And by the way, it is in New Jersey, it is GMO and organic. They are. So that's the standard, as well as being incredibly closely regulated by the state. You have to realize that every plant in New Jersey has a tag on it with a scanner and everything. It's state's tracking this very, very, very closely. It's on the no chemicals and everything. So then you work to figure out exactly how you want to do this, and then you adjust it a little bit yourself, and it's a learning curve. I need a little bit more, I need a little bit less, etc. See, the thing about marijuana, which makes the tragedy of having lost this from the medical pharmacarium, over this 50, 60, 70 years, is marijuana is not addictive. It is not chemically addictive. Can you get dependent on it like you can get anything else? It's possible. But yeah, it's very unlikely in this scenario you're going to. And it is not chemically addictive. You cannot overdose on this. So in the past 3 years, 1,200 people in the United States have overdosed on Tylenol. There has not been a recorded overdose on medical marijuana anywhere at any time, etc. You can take too much, in which case you're going to sleep for a while. And it's possible to have side effects. There are people that this really bothers. It makes them feel a little hyper. Maybe that's the strain. There are occasionally someone that may seem to have hallucinating a little bit from it, although it's not an hallucinogen, etc. It can make you feel lightheaded. Again, if you take too much, it's not completely without side effects, etc. But you can overdose on it, and it has almost no drug-drug interactions. I'd still suggest, if you're going to use it, talk to your physician. What are you taking? What should be monitored? The good example is Coumadin and warfarin, which since it interacts with pretty much everything. We haven't seen interaction in our patients taking blood thinners with this, but it's still worth mentioning to your doctor. This is how I'm going to start doing this. But in theory, you could take it with pain medication. You take it with other sedatives. Now, would I take this the first time with a Xanax? Of course not, because you're taking something that could be sedating with something else that is sedating, and you're not sure what's going to happen. But I would kind of work and adjust this. And it takes time to kind of, figure this out for you. But you go to the dispensary, you sit down with a counselor, they work with you which strain or strains, how you're going to do that, is there any equipment you need, is there any teaching you need, etc. And then you kind of start to work to use this and blend this kind of into your life, and you work it slowly and you move forward. We have, and unfortunately, as I said earlier, you end up paying cash for this, which depending on the patient runs somewhere between $50 and $100, $150 a month. I have people that use more, but it's you have to use a lot of marijuana to spend a lot more than that. The prescription you get, by the way, it's a weird way of writing prescription, state of New Jersey. It is a 1-month prescription, but you can have up to 12 refills. So it's basically, for most doctors, myself, I just write it for 12 refills for a year. And it's also a certain amount, a number of ounces. In theory, in New Jersey, you can write up to 3 ounces. And there's even an exception to that. You can go more, 3 ounces. For those of you that haven't used medical marijuana, 3 ounces is a gigantic amount of marijuana. And unless this is something you've been doing constantly since you're like 20 years old and you're already smoking a lot of marijuana, none of you are going to use 3 ounces. I mean, our average patient uses like ½ an ounce a month, more or less, maybe a little bit more. But the prescription says the maximum amount, and I use just right amount that's higher than they're likely to buy, because you can always buy less. And then the prescriptions for the prescription that the physician writes, the certification is for years. So in a year, you have to touch base that physician again, just to certify again, what the diagnosis. That's the whole closing the loop. The clinician knows what's going on. Your registration that you do is good for a couple of years, and you get a notification when that registration, expires. And you'd have to redo stuff. It's not as hard, as the first time. So we've seen this make an immense difference in a large number of our patients. So first of all, I'm an oncologist, just the experience of having cancer, it just makes you rest better. You're less pain at bedtime or any of the times, less nausea, better appetite, just dealing with the whole journey better. It's kind of gestalt of, the specific things. It just makes a tremendous difference. And I've had patients I had 96-year-old patients, who can get back and go to weddings, because of this, et cetera. And obviously, and I've had women of every age, in between. And so it's just made an immense difference. This turns out to be, and we had no idea about this, we started using it, and now we're starting to see a lot of reports in people in the informal literature. This turns out to be the best drug for neuropathy, period. I had no idea. We had no idea, et cetera. I mean, so we oncologists, we see neuropathy because of our drugs or diseases, but diabetic neuropathy, post-shingles neuropathy, sympathetic neuropathies, nothing works better. Not better, gabapentin, Lyrica, narcotics, steroids, nothing works better for neuropathy than in medical marijuana. I mean, it is just absolutely incredibly fabulous. It really makes an immense difference. So, I mean, it's been a really positive thing, and I would say, significantly more than half of our patients that we prescribe it continue to use it. We've had now patients that are using it for years, for various medical issues, et cetera. I mean, and these are not people that are walking around drooling. These are people that are walking around functioning and strong, and they can use it, and it complements their other medical care. And this has been, an extraordinarily successful sort of a program. We are hopeful in New Jersey, as recreational world, we're going to see more products available, a little ease of use, a little ease of getting the different products available. We're hoping to see more legalization across the United States, more their recognition of state-to-state license and certification. We're still going to see that change. New Jersey is not a grow state, which means you can't grow your own. Which is unfortunate, because it'd be fine to figure out what strain it is and just grow it yourself. That sounds like somebody that was trying to make money, didn't want something to happen, but that's just my bias in life. I wish that it would become a grow state. In Oregon, which was the first state to legalize it, you can grow up to 30 plants. I mean, that's enough for you and your neighborhood, for forever. I'm not quite sure why you need that much, but so I'd like to see New Jersey become a grow state. This is a positive thing. It continues to grow, extraordinarily successful. By the way, the state website is good, and they'll probably kill me for saying this, because they have actually been angry at me saying this before. The state phone number for information, they're really good. They care about this program, so when you have issues, reach out to the state. They are really good about this. They're entering into the program, so it's been a really positive, experience for us. That. So, I mean, this is something that's very exciting, a positive. It adds to the armamentarium of a lot of people dealing with a lot of challenging, sometimes awful diseases, and it can really help people get through. We look forward to this. We continue to plan to continue being involved, going forward. And if you're in that situation that you think it might help, I would strongly consider, thinking about it. And thank you so much for giving me the opportunity to talk about this today.